Okay, great. Let's start with a roll call then.
Oops, you're on mute, Isabel.
There we go. Helen Blanca.
Here.
Chun-Wei Chi.
Here.
Peter Addy. I don't think he's here yet. Gabe Bandine.
Hello.
Thank you. Betsy Boyd Flynn.
I'm here.
Thank you. Mike Durbin.
Here.
Thank you. Rob Fizette. Doesn't look like Rob is here. Tony German.
Present.
Thank you. Eve Gray. Don't see Eve yet. Rosemary Hemmings. I don't see Rosemary yet. Julianne Horner.
Here.
Thank you. Max Kaiser.
Here.
Thank you. Jim McGee. I don't see.
Yeah, Jim said he might only be able to make an hour if that.
Peter Merritt.
Here.
Thank you. Angela McKallick.
Here.
Thank you. Jamie Osborne.
Present.
Thank you. That's everyone.
Great. Well, welcome everyone to the November meeting of the Plan, Design, and Expenditures Committee. A couple of quick updates. Last meeting, I told you that I will be passing over the chair of this committee to my colleague on the board, Judy Richardson. And we were really excited for that change. Judy's super smart about all the issues that we're talking about. And then in the interim, we had one of our board members, Bruce Goldberg, was asked by Governor Kotek to participate in a 6-month task force to address the Medicaid shortage that we anticipate in the fallout from HR 1. And so he has taken a leave of absence from our board, and he was chairing one of our other committees, the Operations Committee, which Judy was on. So Judy's going to remain on the Operations Committee for now and chair that in Bruce's absence. But we're hoping to still eventually transition to having her chair this committee. Another quick update, Tosh Rahman sent his regrets that he has to resign from this committee due to a work conflict that came up for him. So we're super grateful for his input and wish him well. Okay, so we have a busy agenda today. After Mimi's updates, the bulk of our meeting is going to be spent with our Milliman consultant, Ken Laskowski, and that's going to be a really important discussion for us. What Milliman has done for this committee and for the board is work through the best estimate that we have of our current healthcare expenditures in Oregon. This type of assessment was also done back in the task force, but that was 2019, and a lot has changed since 2019 in terms of healthcare. And so they have revised that projection. So what he's going to be showing us today is an estimate of our current healthcare expenditures across the state. And then he's going to project those numbers through to 2030, which is the date that we're estimating this plan would take effect. So if this is what we spend today, and if nothing changed at all, here's what we would be spending in 2030. And then he's going to put side by side with that for us what the projected expenditures would be for the Universal Health Plan as we've designed it. As you all remember, this committee proposed an enhanced version of PEB benefits that would be available to all residents in Oregon. And so what would that cost? What would it look like? How would it play out? And so then we'll get a side-by-side in 2030 numbers. If we did nothing, here's what expenditures would be. If we gave everybody enhanced PEB benefits, here's what that would look like. And it'll give us a chance to evaluate that. That's going to be really important for us because this committee will be tasked with working with our Finance and Revenue Committee to try and match up. So they're coming up with a revenue strategy with estimates of how much money they think they can raise. And then it's our job to work with those numbers with what we think our expenditures will be and see if there are any adjustments that need to be made. So it's going to be the basis for a lot of our decision making. So we're looking forward to that presentation and hope you all get a lot out of that. And then after that, we have 2 straw proposals to consider. It's the quality straw proposal and then a hospital payment straw proposal. Those shouldn't be any new information. We'll just kind of confirm that those are ready to go before the board and hopefully present those at the board's November meeting. And then Lee Hastings is here to do a review of long-term services and supports. Long-term services and supports is sort of this remnant of our work that we haven't fully addressed yet. This committee agreed that we would defer deeper work on long-term services and supports to a small task force. In lieu of convening a task force, our staff is going to be investigating more deeply into this issue and pulling in experts as needed from around the state. So Lee's going to give us a basic overview of that so that we can ultimately make a recommendation about long-term services and supports. So it's a lot, but I'm glad you're all here for input. And with that, I will pass it to Mimi.
All right. Thank you, Helen, and good afternoon, everyone. This is Mimi McDonald. I'm the Executive Director of the Universal Health Plan Governance Board. First off, we'll start with follow-up from our past meeting in October. A lot of these bullet points are going to be addressed today. As Helen just mentioned, the benefit and plan design, Millen is providing the cost analysis of this proposed benefit package. So that's will be addressed today. Also, the quality of care policy and strategy straw proposal. We went through it in detail at our last meeting. So this meeting, 2 slides and the revised edition is available for people to check out, and we will have a vote on that. We did do a behavioral health overview in our last meeting, and that will be coming up again. That's not going to be addressed at today's meeting. But a couple of the call outs that we are going to be sure and address that people asked for was for state behavioral health funding data for the 2025-2027 biennium, which will be provided. And then also, if it's possible, some cost payment information regarding the specifics around mandated behavioral health services. And then lastly, again, from follow-up from our last meeting, the hospital payment system will be coming up again today. So can I go on to the next slide? All right, so what has the board and the other committees been up to? Oh, so much. So the board at the last meeting did spend a significant amount of time reviewing the revenue proposal that came from Finance and Revenue, surprisingly. That will be presented again in further detail at this upcoming board meeting, which is on the 20th of November. So that will be a great discussion. Other things that are going to be at this upcoming board meeting, our community engagement and communications team did a great had a great meeting with the board specifically about a communications policy update, which went really well, and that will be presented for the update for review and then approval. We will be, the board will be looking at the quality straw proposal that we are hoping will get passed today, as well as the hospital payment straw proposal. Additional things the board will be reviewing are the administrative structure proposal that is coming through operations and a finalization of the mission statement. This has gone through several iterations, has been reviewed by our Community Engagement and Communications Committee, and is coming back to the board for a final review. It's sort of a vote between 2 choices. Next, the CECC committee has been, as I mentioned, working very hard. There are now documents that are available, one-pagers that have a synopsis of the work that has been happening with the board, with great work from the the committee itself, and also Patty Wentz, who's our consultant, and our committee chairs have done a terrific amount of work on that. And really the committee has shifted now. The work is on planning the targeted engagement meetings where some information about the proposal will go to these different groups, and then we'll be able to get feedback. Next, operations. I apologize. The bullet points after operations, I didn't have time to change it on today's slide. So what will be happening at this upcoming operations committee meeting, there'll be a discussion actually about the operational workings of primary care and behavioral health payment system. So that's going to be very interesting. There'll also be further discussion. This group has already talked significantly about eligibility, but the operations side of that is eligibility and enrollment. So that discussion will be happening as well at the next operations meeting, and bringing up a transitions committee and what that will look like and what people on the operations team think should be involved into that. Then lastly, finance and revenue. The revenue proposal is still being reviewed. There is an interim finance and revenue committee meeting. It's on a little bit of a strange date. It's coming up on a Thursday. Usually those are on Tuesdays, but it's Thursday the 13th. In addition to the revenue proposal, so that is going to be the sole agenda item for that meeting on the 13th. But then, of course, also the F&R committee is looking at the distributional analysis of that revenue plan. And then also doing a much deeper dive into startup costs and reserves. So there's any questions, I will take them, or any additions from Helen or Judy about what's going on at the board. Nope. Okay, sounds good. We'll go on to the next slide. Thank you. Which means turning it over to Ken Laskowski and Fritz.
All right, very good. I am going to share my screen. I'm going to go ahead and lead the presentation today. I've got Ken, of course, with me. So Ken's done all the work. And I get to present as though I've done the work. But in any case, Ken is here to assist me. We also have Kate Shadell from the Operations and Admin Committee, so I appreciate her joining as well. While I do my screen sharing here, I just wanted to say thank you for the large swath of time that you're giving us today. We feel good about where we're at on the projections in terms of the range. We've got some work to do, which we'll show you, but we are anxious for your feedback because you all are going to, you live and breathe in Oregon. You've got a lot of experience there. We've gotten up to speed as fast as we can, but there's nothing like being immersed in it the way you have for how many years of your life. So we are very anxious for your input. I don't know that we have 90 minutes of us if we just went through the slides. I asked for 90 minutes in case there are sidebar conversations, people have questions, and that kind of thing. So anxious to hear that as well. And for those of you that don't, I believe everybody knows us by this point, but we'll just do a quick introduction of myself and Ken. And I'm Fritz Bush. I'm a principal and consulting actuary at Milliman. I've been with Milliman about 10 years, about 30, I'm losing track, about 33 years in the business now so far. And just wanted to thank the UHB for having us, being a part of this really important, ambitious, and very interesting project. So we're glad to be aboard, and I'll turn it over to Ken real quick.
Yeah, my name's Ken Laskowski. I'm a senior consulting actuary here at Milliman, and I've been with Milliman for my entire career for 20 years now. I was going to say that I'm happy to take all the credit that Helen gave me here, even though Fritz is leading the presentation. But yeah, I will be peppering in here with any thoughts. And I had the same thing to say that Fritz had already said, that we really welcome feedback. And I'm very interested to hear your reactions and to hear any thoughts that you may have. But excited to be here.
Okay, Thank you. Now, just real quick, logistically, which screen do you see on? Do you see the one with the notes off to the side that says caveats?
Yep.
Yep.
Okay. So let me see what I can do to briefly fix that. Zoom is always a little bit of a mystery for me, because I don't use it as much. Let me see if I can do this correctly. Let's see, which one do I want to pick?
So the caveats screen is gone now.
But you're probably seeing the notes off to the side. Is that
Right, so you
Yeah.
can go up to slideshow at the top and in your tabs is the one that says slideshow. Left of that,
slide up here?
left in the, so file, home, insert.
Oh, okay.
Yeah, so see the slideshow? No, so
So I can do that down here too. So let me do that and see if this does it correctly. I apologize for this. I probably getting the same thing again, aren't you?
Yep.
Let's
Fritz,
try
you can
that.
just go to that display settings at the top and then swap it. It should work.
How about that?
yes.
Yeah.
Ah, there we go. Sweet. Okay. All right. Let's get going. We got plenty to cover here. So, all right. So first thing to notice and to go through here is, why is this not moving? There we go. Don't read these caveats. All this is really to say is these are estimates. That's it. Get all this wording in there to say that these are draft results. All right. And they are draft in the sense that, like we said, we have some items where the way I like to put it is we build a model and we have hooks, and some things we have hung on those hooks, other ones are empty hooks. And then based on your feedback, we want to change some of the stuff potentially. However, you're probably wondering, okay, well, how drafty is draft? So what I would say to that is we believe that our range is reasonable. So when you see the estimates, you've probably already seen it. You know that they're higher than Optimus. There's reasons for that we'll go through. So we do believe that we're going to come out higher than what Optimus said for 2030. And our range probably will change. Now, if I want to tip my hand a little bit more, I would say the upper end of our range will probably come down. There's a few items that we'll go through where I feel like we may be heavy, and maybe we want to offset or come down on particular assumptions. But like I said, I think the range is reasonably accurate. So Helen already hinted at this, but we're going to go through, kind of talk about what we did very quickly on the expenditure process, just kind of a high-level overview. We're going to show you the draft results and do a comparison to the last estimate that was done, which was the task force Optimus estimate. And then we're going to go through each of the steps. We'll talk about what's in the baseline. We'll do the projection. And then probably the biggest piece of this projection to 2030 is that transition period between the 2030 status quo and then going to the UHP. So there's a number of adjustments there that we'll go through. And then we will give you an overview of what we feel is the adjustments that we want to make after this meeting. So we will have an update for you in the December PD&E meeting. Those updates will include some of the empty hooks, things that we don't have done yet, things that we want to revise, and then any feedback that you have for us today. All right. So with that, let's talk briefly about, I'm going to move, I don't know if you can see this. I'm going to move it in case you can. All right. So again, very quickly, we start with a baseline. We do a 2026 checkpoint, just comparing to Optimus. Again, that kind of anchors people and puts some context around the numbers. Trend up to 2030 status quo. And then we add in the UHP adjustment. So our baseline, as you'll see in a moment, our sources vary by market. We try to pick the most up-to-date source, so there's less projection. So it varies by source, anywhere from 2023 to 2025, which is a little bit different than what we do it just a little bit differently, which you might expect. To get to 2026, we put in cost trends, so either 1, 2, or 3 years of cost trend, some population growth, and then there's some one-time impacts going into 2026, such as HR1. Some of these we're all familiar with, right? HR1, expiration of APTCs, things like that. Add a little bit more cost trend, more population growth to get to 2030 status quo. And then we add in the UHP impacts. I've listed a couple of them there, but we'll go through those in a little bit more detail. But obviously the big ones are PEB Plus, this concept of the enhanced benefit package, the adverse selection, potential migration from other states, induced utilization from eliminating cost sharing, and then there's some additional miscellaneous costs.
Yeah, Fritz, the only thing I'll add in there, Fritz, is in terms of Medicaid, HR1 impacts on Medicaid, we did shift that more to 2027.
Okay, yep, good point. Thank you. All right. So let's get to some numbers. I apologize, we're actuaries, we do a lot of numbers, but I will help you to the best of my ability to train your eyes on where we want to look on these slides. But obviously the green numbers up top, our expenditure range right now is between 78 and let's just call that 90 million. Okay, so about a 12 million gap there between various things that we've used to frame up our low and our high scenario.
Billion.
Oh, did I say million? Oh.
Yeah.
Okay. Well, whenever I say million in this, just assume it's billion, okay? Because it's all billion. All right, thank you. So obviously, first set of numbers on the slide, we have our status quo. So this is 2030 pre-UHP. And you can see our numbers are bracketing the Optimus status quo there, a little bit higher on our high end, a little bit lower on our low end, but right near that 70 million range. When you go to the UHP, you can see that gap widens quite a bit. In fact, the Optimus number goes down, and there's reasons for that. I'm going to wait to talk about that until the next slide. And then our estimate goes up, and so that gap widens pretty materially. And I'll show you a reconciliation of that here in just a minute. Okay.
Fritz, we have a question already.
Oh, good. Oh, yeah. Keep an eye on that because I moved that off to the side here. Yeah, go ahead.
Thank you. So I'm just wanting to call out to us all the little parentheses that says billions. So when we're talking about this, the expenditure range from 77.9 billion to 89.9 billion. Is that correct?
That is correct.
Yes.
Thank you.
Yep. All right. All right. From a population standpoint, not much different, right around 4.5 for both Optimus and Milliman. When you go to UHP, we go up a little bit because we added in I'm blanking on the name, the resident
Non-resident workers.
Non-resident workers, thank you. I could see it, but couldn't say it. And so the way our methodology works is we essentially balance back to a population estimate, but population estimates don't include people living they're working there. They're living in other states, and we'll get to this a little bit more, but since I'm on it right now, I'll keep going. So we add that on. Now, presumably in that cost, there's a revenue offset. I know that's been discussed in the Finance and Revenue Committee, and I think, Helen, you have a question.
Yeah, we decided we are not covering non-resident workers. That the foundation for eligibility for the UHP is that you live here, not that you work here. And when they work in Oregon but live in other states, they would not be covered.
Perfect. We can make that change. That'll bring that down. You'll see here in just a minute, I think 3 billion is what that's worth. All right.
If I could add something there,
yeah.
Which is a little bit more vague, was yes, the decision was made not to cover the non-resident workers. However, there was also a discussion about in some way being able to provide support to those people, either by, so I don't think that there was a specific rationale for that. So it's either somehow not having the employers pay the certain amount of tax that they might have, or it hasn't really been firmed up, but I think that there is some discussion, or has been, in the eligibility proposal about that. So we can look into that a little bit more detail, because I don't want to completely remove that group off the table and the expense.
Yeah, good points. And that's obviously where we want to coordinate with you all and revenue as well, so that everybody's making the same assumption.
Yeah, one other difference in the population there is this adverse selection population that we'll talk about later as well. The assumption of people that will move into Oregon, as well as people that will move out of Oregon as a result of the implementation of the Universal Health Plan.
And that's I've got a slide up. We've got a slide on that right after this one. But I added this slide, and Mimi, I'll send you an updated deck. Everything else is the same what we sent you, but I felt like this needed to be drilled down on just a minute, or just for a second here. So the methodology that Optimus used makes direct comparisons of these numbers as they sit, a little bit less, let's just say less than optimal, because they actually have an estimate. So let me go back real quick. If you notice, I pointed out before that they went in status quo, they went from 71.7 down to 70.2. Part of that is that they are defining expenditures in total. So this is all the benefit plan expense and the admin expense that is associated with it. So one of the things in their projection was they said, oh, the admin expense is going to go down. So that's part of what's contributing to that decline there, along with some of the other things that I'll talk. We have different estimates in terms of the benefits and the anti-selection, but that's part of the reasons why their estimate goes down. So when you compare our numbers at this point, like I said, this is not complete, because our estimate of expenditures right now is what we would call the allowed amounts. It's the total amount that's going to get paid to the provider. Meaning, under the current system, it's the amount paid by the third-party payer, whether that's Medicare, Medicaid, what have you, plus the cost sharing, right? So that's the total amount that would hypothetically go to the provider. It's what we call the allowed amount. So it's the medical and the pharmacy expenditures. And that's what our 77.9 to 89.8 is there. The operating expense would come from Kate and Stephanie's team from Milliman, and that would be layered on that. It's just, so the reason we compare, so I really need to call that out, that the different methodologies between Optimus and the way we're going about this, with having, each of these quantified separately, this is just simply the best comparison point that we have, but it's not perfect. I think ultimately where we would go is, if you wanted to continue to compare Optimus, we would layer in Milliman's estimate, which is not ready yet, of the operating expense. Okay, so it's a really important caveat, especially for people who maybe aren't in this meeting. They maybe go out publicly, pull this deck down, and they might do a comparison. So we just wanted to make sure we were super clear about that. Okay, but with that in mind, we're going to continue to just do a quick comparison here of what's driving this difference between Optimus. I picked our high estimate. Okay, I could do a reconciliation with the low one too, but we don't need to do both. It would be the same things, only smaller numbers. But you can see we have an estimate in there for non-resident workers. Obviously, based on the previous conversation, that will change. It may go to 0. Doesn't sound like it will, but it will be smaller probably than what we have here. But that's what's in there now. Okay. The PEB Plus benefits adds about $2.5 billion to the status quo. I'm sorry, to the Optimus. Optimus had an estimate in there for this, but as an example, so the bulk of the PEB Plus is dental. That's the bulk of the cost in there. I want to say it's like, Ken, you can check me on this, but it's like 80% of that cost. And so they had an estimate in there, but our estimate for the PEB Plus, particularly the dental, is much higher than that. The induced utilization, Optimus also had an estimate in there for that. We have an estimate in there on the utilization as well. That's how much more 4.3 billion we are than them. I hinted earlier that the top of our range could come down. And that's one area where I think it could, that induced utilization could be a little bit heavy, or could be correct, but it needs some offsets for things like medical management and other things, but we can talk to that. Okay, I see Betsy has a question.
Yeah, thank you. First question is, can you define induced utilization a little more clearly?
Yep.
The assumption that that would all be wasted care, or that is care that people will now get that they wouldn't have gotten under the status quo? That you know, that some percentage of which is justifiable and some percentage of which may be excess utilization.
Yeah, great question. Actually, really good question, because you're getting right to the heart of the matter here. So what it is that there is a known and probably indisputable phenomena that when you increase member cost sharing, enrollee cost sharing, whatever you want to call it, through deductibles, copays, and coinsurance, utilization goes down. That's probably undisputed, and Milliman has its models that it uses to sort of estimate this. The question, though, that you're bringing up is the part where we need a little bit more refinement on our estimate, because as we know, cost sharing is arguably the #1 barrier to getting the care that you need. I don't think anybody disagrees with that either. Even proponents of people that believe cost sharing is needed probably don't disagree with that. People forego care that they need because they have a high deductible health plan, they have nothing in their HSA, and they're looking at a $1,500 colonoscopy that they don't have the money for, right? So they're not going to do it. The flip side of that is the idea behind cost sharing is two things. One is to make sure that care is discriminate, both on the basis of the patient and the provider, and that optimal levels of care are being used, that people are not just simply running to, best example, ER. You don't want people going to the ER if they have access to, say, their PCP. And so a lot of plans will put, a $500 copay on an ER so that people think twice, like, well, do I really need to run to the ER, or can I wait, or can I call my can I call my telehealth nurse, right? Get their opinion first. So that's the idea. Whether you agree with that or not, completely up to you, but that is the idea. So to your point, Betsy, I think that there is a little bit of both in that you could be looking at care that is being foregone and needed and is therefore now going to be received, and you potentially prevent an acute exacerbation that you would have otherwise been dealing with. On the other hand, you could also be dealing with indiscriminate, let's just call it, use, but not only by the choices people make, but potentially by doctor, physician, or other provider practice patterns. So that's a long-winded answer of a way of saying probably a mixed bag on that one.
Helpful, thank you.
And then let's see, I forgot where I left off. So,
we have a couple more hands up too.
Oh my goodness. Let's see who we have. Jamie?
Jamie and Helen, yeah.
Yep.
I was just curious about the methodology of limited access when we're trying to project increased utilization. And it's complicated, as you mentioned. So if we say everyone has access and expect that means that everyone will receive that care, I think it's erroneous, because we don't have enough primary care providers, we don't have enough specialists, and in many places we don't have enough ER. And so,
Yeah.
So I'm just thinking a little bit about that. Increased utilization may not happen immediately right up front, but that might be more of a stepwise utilization as access becomes available. Right now, no one in Coos County can get access to primary care because there isn't any.
Nobody there. Yeah.
There's nobody there, you know, so
I-
how might we consider factoring in access limitations? For example, could we use wait times, or, you know, like how long does it take in this county to get a primary care appointment or a
Yeah.
specialty appointment?
Yeah, no, I think your point is well said. There's other things that go into maybe a haircut on this. That would be a haircut that we might put in, and it's not one that you necessarily want, right? That's you don't want to be reducing your estimates of cost because people don't have access to it. But if that's the reality, that's the reality. There's also an interplay on induced utilization with medical management, right? There's only one of the things we don't have in there yet is we're basically assuming what I would call industry standard medical management capabilities. So in other words, we have a zero estimate in there because we assume status quo. And if that's the case, there probably is a logical limit in a lot of cases to, even if somebody has zero cost sharing, there would be medical management limitations in terms of what they could realistically receive. So not only do you have the access, but you have this medical management crossing paths, but with some of this utilization, and that's not really baked in yet to the 4.3. But I agree with you. There's probably ways, Jamie, and I'm sorry. Oh yeah, it was Jamie. That we can look at, say, like hospital. We can look at geo access. You can look at hospital capacity. PCPs per thousand by geographic region, things like that. That you can get a qualitative sense. I don't know that we have time or expense to do a full blown quantitative view of that, but you can definitely get qualitative indicators of what access is and maybe could be under UHP. All right, Helen, you had your hand up too.
Yeah, I wonder if you could just quickly say something about how you estimated the adverse selection box. Like, that seems like a really tricky thing in terms of like numbers of people and cost.
Yeah. I'll give you a choice, Helen. Do you want to go to the slide that we actually have prepared?
Oh yeah, yeah. Then we can wait. I can wait.
Or do you want to wait? Yeah, because we do have a nice little
Okay.
slide. Yeah, but all right, and then just very quickly, we have between us and Optimus, there was obviously there's 6 years worth of data difference, or 5 or so years of data difference. So as you know, in the last 5 years, there's been a few things that have happened, like that thing that rhymes with COVID, and all of the other stuff that went along with it. So plus you just have a natural restatement of projections that happens over time. The actuaries are wrong, and then you have to restate it one way or the other. All right. I'm not going to spend a lot of time on this because this is just really a reconciliation of, and because the beginning, these purple boxes are so close between the two, these numbers are a lot the same. We do have a little bit different here on the uninsured. We do project that the uninsured who are not getting the full care that they need because they have financial barriers to doing so, would their utilization and cost would come up to something akin to, say, what's in the commercial market. So it would come up, to, now that they're insured, they would be something like that in the commercial market. So that's the only difference there. All right, so that's just intended to be high level to begin with. Very quickly, these are estimates here that are actually they're essentially in both the status quo in 2030 and in UHP. Okay, so it's bringing both of them up. It's not so much a differential anymore. We're just pointing out to you that there's additional cost baked into here that probably Optimus had no view of when they did this. For example, GLP-1s for weight loss weren't even a thought back then, right? They existed, but not in the form that they do now. Gene cell therapy, same thing, kind of exploding. Not as high profile as GLP-1, but there's some serious cost going on there. So that's going to grow. And then we added the other things in there, for gender affirming care, not a lot there. Gene cell therapy, the insulin cap, That's actually, Ken, correct me if I'm wrong, that's not actually zero, it just doesn't register on the,
Correct.
yeah.
Yeah, it's just less than 100 million. Yeah.
yeah. So we have it in there. It's just, it doesn't, it's pretty small. And then we have the placeholder, and you all mentioned this at the beginning for the behavioral health. What we have in there is about $1 billion. I think it's the actual number is like I think it's like 800 million each year. We have a source on that. I know that that number is going to be revised, but again, kind of like the non-resident workers, we can put in the number that we feel like is the accurate number. That right now, that's a placeholder. The documentation that we have though says the legislature passed $1.9 billion, I think.
Yeah, well, about 1.8 billion, and then we shaved we didn't include every item that we felt was, so if something we felt wasn't an expenditure, we didn't include it. And in this particular scenario we're showing here, the highest scenario, we did increase that behavioral estimate by an additional amount, just to get another high range in case that there more funding is committed to behavioral health.
Yeah. And then the last one is just the uncompensated Medicaid. So we have a report from, I think it's OHA, that kind of show, I don't think it was OHA, but Ken, you can find the source if folks are interested in it. But basically, it's the uncompensated care report. And we're projecting that actually goes away, but that's actually offset by the uninsured as well. So that's those two kind of, they're not the exact same thing, but but in terms of cost, they do kind of offset. But we assume that any uncompensated care in the hospitals, you know, would be offset by the uninsured. All right. Don't have to spend a lot of time on this because we're going to talk about this a little bit later. But again, this is an example of where we have things sort of built in here, but they are currently zero. We either don't have an adjustment for it yet, or we just, you know, we have to get input from you, or we just want to revise it with additional information. Good example is RX rebate adjustment. So we don't really know anything about what the RX procurement and formulary and those, you know, the overall program of the RX benefit is going to look like. And RX rebates are obviously a function of the PBM, the formulary, negotiating power, all that kind of good stuff. So it basically, again, assumes status quo. We'll have a slide here in a minute for provider reimbursement. And so we'll skip over that real quick. We know fraud, waste, and abuse, you know, is important. It's we assume industry standard there as well. Currently, same with medical management. The morbidity changes are currently zero, although I think there is a case for assuming that morbidity would improve. I wouldn't say that it's going to improve miraculously. I don't think universal healthcare has any hopes or dreams of curing people's you know, chronic condition or anything like that. But I do think that, again, given the access improvement, could actually result in healthcare, or excuse me, morbidity improvements. But currently zero. All right. Okay, we're going to zip through some of these. We've talked about these a little bit already. We have the baseline enrollment estimates fairly close on 2026 with Optimus. You can see between, you know, sort of the split between the public plans, which public, by the way, the ones that are labeled is your PEB OEB plan. Those are combined. Then you have employer, and then the individual market, and then the Medicare, Medicaid.
Yeah, one thing I want to pipe in right here real quick for Medicaid, just so no one gets confused. So the Medicaid numbers are based off of June 2025, and the OHA website is going to report about 1.4 5 million or so for Medicaid. We've stuck duals into that, including partial duals as well. So that's where that little difference is.
Yeah, so different. So that's probably the one number there that sticks out differently from Optimus is we seem to have a different trade-off between employer, where their number is higher, ours is lower. Our Medicaid number is higher, theirs was lower. That is going to bias our estimates slightly upward, not a ton, but we're definitely open to discussing, for example, like Ken said, the treatment of duals is where those actually the federal reporting on this is somewhat strange. There's a report for Medicaid, there's one for Medicare, and then they have a separate report for duals. And honestly, I've been doing this for 10 years. I can't tell where they include that, and I've never gotten a definitive answer from anybody who. So if you know, I'm all ears. So right now we have them in there as a separate population. But again, I would point out that those differences there don't make a huge. There's other things that are driving the cost much more than this population difference. These are our sources. Put it in here for completeness. If anybody accesses this report and that online, this will be online. These should be clickable links. So this is just a way for people to go out and say, hey, I wonder where they got this, and they can go out and at least look at the sources that we used for this. But as you can tell, in the source column there, it's a mix of 23, 24, and then we have one 25 report. So trying to get the most up-to-date numbers we can. We did make some adjustments very quickly. We, of course, have the impacts of HR 1 on both Medicaid and Medicare. We have the APTCs going away. We do have some shifting from small group, as small group in most states is still declining. Fully insured, by the way, is the FI, just so you're aware. That means fully insured. And that market is tending to decline. They're either going to the individual market for ICRAs through ICRAs, or they are going to a level funded, which drops them into the line right below it, their employer self-insured. So some movement there. We also, when we project the population up to the 2030 status quo, we do make a difference between under 65 and over 65. So the over 65 is growing. As you know, we have an aging population, so that has a higher growth rate. So we continue to push that forward. We actually just use the let's see here. Total population comes from this right here. So we're just taking their estimate of by population. So we don't actually do our own projection of that. We just rely on that, and they have a difference between the over 65 and the under 65. Okay. So we've talked about volume. Oopsie, sorry about that. We've talked about volume, membership volume, enrollee volume. This is the per member cost now. And you can see the baseline, our baseline versus Optimus. Now, I'm sorry, going back to, this is a comparison again to 2026. You can see all of our per member costs are lower. Again, part of that is the way Optimus measured expenditures. They have the admin piece on at least a significant portion of these lines, maybe not the uninsured, that has an admin piece. Okay, so that's why you see, generally, that's why you're going to see our per unit numbers a little bit lower. And then you can see baseline. We have a little bit of, when you multiply these numbers, oh, sorry about that. When you multiply these numbers over here against our previous population, you get the expenditures. And when you combine that, you can see our baseline starts, our 2026 comparison starts about 4% lower. When we go to 2030, we make up that deficit. But again,
hey, Fritz, this is Mimi. Sorry to interrupt. Yep. Can I ask you a question then? Do you think that is that 4% totally the administration, sort of the difference between the administrative costs that Optimus has rolled into it versus your baseline?
Yeah, you can see, I could go back a slide and you could see, remember that the population was close. And you can see the 4.1 and the 5.4 are pretty close together. So our 2026 estimate, again, the idea behind comparing to 2026 is this is just kind of a way stop, right? This is just kind of a way of grounding us. So So we're reasonably close. Most of it is the per unit cost, which we attribute to, most of the difference is the per unit cost, which we're attributing to the fact that they use a number that's probably loaded with some amount of the administrative cost, if not all of it.
Got it. Thanks.
All right, again, sources, if people want to.
Jamie has her hand up too. Sorry.
Oh, goodness, I gotta pay attention here. Yeah, go ahead, Jamie.
I noticed on the last slide, it said this slide excludes costs for behavioral health. Can you say something about that, or will that be included later in a slide?
That's specific to that enhanced behavioral health that we added on the 1.8 billion that Fritz was referencing. So that committed to in the governor's budget. So it doesn't exclude behavioral health services. It's just when we conceptualize adding that extra $1 billion on for that behavioral health enhancement, that's not included in the PMPM. Does that make sense?
It includes behavioral health in the sense that whatever is currently included in public employer, like the current coverage, it covers those. It's covered under that.
Well, that's my concern, is that behavioral health coverage sucks in those spaces. And our proposal is that we enhance the access to behavioral health services because we think that's going to reduce total cost of care.
Yeah. Don't disagree. This is just more of a, like, this is what it is. Now I agree with you. When we get to the 2030, as Ken said, we do include that amount that's in the budget for the enhanced behavioral services. Yeah, so I think we're all good, but I don't disagree with what you say either. Okay, let's see, did that. Okay, so let's talk about provider reimbursement assumptions. This, just to be clear, this is sort of a standalone piece of analysis. And the reason I say that is because it's an estimate of what we think is baked into these numbers. Okay, so this is our own independent. Milliman does this type of analysis on any number of bases where we look at reimbursement as a percentage of Medicare. We have access to the APAC data, which we can run Medicare repricing software to actually reprice the claims that are in the APCD and get an exact, or well, I should say a good estimate based on actual claims experience for what do we have, Ken? 2024?
2023.
2023. But so these estimates are what come from our own they're Oregon specific, but they are estimates based upon our own independent research. So this is our estimate at this point for what we think is baked in there. Okay, so you can kind of see there as in an aggregate, it's about 115%. Excuse me, that's driven obviously by the fact that Medicaid is a very large percentage of the enrollment, and it's at roughly 88%. And then Medicare, of course, is at 100. And then the other commercial market and PAB are close, hovering around 200. Excuse me. And we know, of course, that PAB has the 200% cap on hospital. And that should be baked in there. I think the 192 felt pretty good for the PAB OAB. I think one thing to point out here is that the Medicaid number is a little bit squishy simply because there's state-directed payments. We're probably all at least somewhat familiar with those that don't show up, in any analysis that you would run on, say, like if you were to reprice all of the claims on a per unit basis, the supplemental payments would not show up in there. So that's why we take the Medicaid number that we have, which is about 80%, and we assume that there's $2 billion. Is that right, Ken? Let's see.
Yeah.
Yeah.
Yes.
In supplemental payments. which pushes that up. So that's our estimate for Medicaid. So where this obviously becomes important is when we start considering things like, well, you know, first of all, how close are they to Medicare already in aggregate? So they're around 115. That number is subject to revision, of course. You know, all of these providers are going to, their collectability problem on cost sharing is going to evaporate under UHP, right? So that's one thing that's really important to remember. Collectability on deductibles and coinsurance is like 30%. So they're not getting much on that, and that's going to evaporate. If there's no cost sharing, you don't have a collectability problem. And then, of course, you have the admin component that they charge for all of the administration that goes on. So there's you know, when that question of, well, what should we pay providers comes in, those are all the things that kind of get baked into that, is sort of this starting point, and then what are the puts and takes as you move to UHP. All right, so let's go on to status quo. I'm not going to spend a lot of time on this. We're just really, again, projecting a couple years forward. One thing I would point out here is, if you can see my cursor, you see some pretty notable changes in uninsured. This 122 was from, I think it's the OHA's uninsured report. So it's pretty low right now, which is great. But with the disenrollment from individual that's going to occur with APTCs, you're first going to see a drop, but then we have an increase in individual coming from ICRAs, from small group. But then you see the Medicaid drop that we have forecasted as well. And those are basically moving into the uninsured. In terms of trend, you know, we have two different trend estimates. We do not use national health expenditures trends direct. Well, I take that back. We do, but we do some adjustment of the national health expenditures trend. For example, we took out COVID. So basically, we look at national health expenditures and we pick that range based on roughly the last 10 years. We don't use the Oregon cost target, which is 3.4%. Now, if someone can give me a compelling reason and something tangible that would say, oh, we're going to be able to hold cost to that, I'd be willing to drop that number. Amy's shaking her head like, yeah, not going to happen. So I just want to make you aware that we are aware of that number, but we're not using it. All right, this slide is I'm going to go quickly over this. This is just really taking our 2026, projecting it forward. You can see using the 5.3, the 7.4. We also include, as we noted before, changes to the GLP-1, having those ramp up in terms of penetration. The legislative changes, which, as you recall, were pretty minor, and then the other things like cell and gene therapy. So I think we've talked about most of that. All right, and then again, this is very similar to, actually, this is the exact same slide as before. So I just wanted to point out the fact that we actually do consider these things in the UHP estimate. So I'm not going to spend any more time on that. Duplicate side. Okay, now we get to the fun stuff. So anybody have their hand up? Oh, Jamie does.
Good question.
I was pausing to make sure that didn't have it. Yeah, go ahead, Jamie.
There is, as we're looking forward, there's one other consideration is certainly GLP-1s are incredibly costly, but just to throw this into consideration and be watching for it, because Oregon has such a large retiree population, there are some treatments emerging for Alzheimer's disease, which are insanely expensive and onerous, do not have incredible clinical promise, but I expect those to be hitting expenditures probably in the next 12 months. We'll be starting to see that happen. So just want to call it, it's a monoclonal antibody, and as you know, those are super expensive. And just because that's such a large population right now, that's another group of medications that we might want to keep an eye on. Of course, we could, choose to have that be a pretty tight prior auth process. But just because we have a large population of retirees, I think it's salient.
Okay. Shunwei?
Yes, I have a question about projection of future payment. There is one figure, the board is still trying to get a more accurate estimate. That is, once the universal health plan is implemented, there will be substantial reduction of administrative costs, particularly on the billing from the provider side. And that, when we get a more accurate estimation, will be an adjustment to modify the future payment. And in your projection, how do you incorporate that?
Good question. The answer is going to be short. We don't have anything in there for that right now. But that was, I touched on that along with the idea that, their costs, provider costs would presumably go down for things like negotiating contracts, what have you, billing, what have you. On the same token, with the elimination of cost sharing, their revenue is going to go automatically up on about, let's say cost sharing, I think, is roughly 15% right now. If you eliminate the collectability issue on that's going to be, 5 or 6 points increase from, let me just go back here real quick. That's going to be about 5 or 6. Where were we at here? I mean, I don't know this. Did I pass it, Ken? What slide is the provider? Did I pass it already? No, I didn't.
No, keep going
Yeah.
back.
Yeah. There we go.
Right
So with that 115, that number is not really 115. It's actually less than that, right? Because they have such a collectability problem right now. So that number is maybe on a cash basis is maybe like 112. And it's just a guess. Okay, just hypothetical numbers here. So they're gonna get an actual cash increase when UHP solves the collectability problem, particularly on patient cost sharing. And by the way, just as a side note, providers have a collectability problem on third-party payers as well. It's not nearly as big, but they have that as well, and presumably their revenue would go up there as well. And then Chinwei, to your and I hope I'm pronouncing your name right. Is Chunwei? I think. Okay, very good. Then they'll have a reduced cost as well because of the billing. So you've got at least on a cash basis a bump up in revenue and a bump down in cost for them, which combined would suggest that you could bring down their overall reimbursement. Now that's purely conjecture, in my opinion, at this point. I'm just telling you directionally, that you've got some puts and takes there when it comes to the provider reimbursement. But again, short answer is nothing in there right now for that.
Thank you.
All right, let me get back to where we were.
Yeah, we had another hand.
Question, Helen?
Yeah, just following up on Chunwei's question. So Optimus projected 4% administrative savings. And right now, our current Finance and Revenue Committee adjusted that, and they're assuming 8% administrative savings. But in these numbers you're showing us, you're not including either that 4% or that 8%. It's just, you're just saying right now it might be a wash because there might be pros and cons on both sides administratively.
Yeah, yes, but we're mixing so you're talking about plan UHP administrative expenses.
Right.
Chun Wei was talking about what is the provider's administrative expenses. That's what he was referring, assuming I understood his question correctly, but that's what he was, which is different than the UHP's administrative expenses.
I see. Right. I see what you're saying. Yeah. So, okay.
Okay, all right, let's keep moving. So this is a grid you've seen before. This is just really sort of a summary of essentially the public markets, by Medicare, Medicaid, and then, the commercial markets, group and individual, compared to PEB. And so we have this concept of PEB Plus that we've built in to our projection. And this is sort of our summary of where we see the additional benefits that are typically not covered, although you can see that there's a lot of optionals on there. And something might be optional for different reasons depending on which market that you're in. So for example, in the group market, a self-insured employer could cover sleep studies. But another self-insured employer may not want to cover sleep studies. So I mean, unless it's a state mandate, which I don't think it is, but a lot of times ERISA groups are even exempt from state mandates. But that's why, Mimi, you're kind of you look skeptical. Were you not? Do you have a comment on that?
I think sometimes sleep studies are highly there's a lot of utilization management, but in general, especially for the Medicare population, they will be covered. Lots of times you have to do a home sleep studies first, but it's almost always covered. So
okay.
So my husband's a sleep doctor, so
Oh, okay. Well, that's why.
That's why I had that face on.
Oh, man. I'm glad I didn't start arguing sleep studies with you, because you would.
No. I am Switzerland on that.
Yeah. So in any case, I think, a lot of these are really, especially in the group market, it's very hard to necessarily pin down like one blanket statement about, say, massage therapy or complementary medicine, because so much of the market is large group benefits and that are usually with the carrier, or if they're self-insured, they have the ability to tailor their benefits a lot more than certainly more than the small group market. And so that's what really drives a lot of these optionals here. When we get to the biggest driver of these, by the way, most of these are very minor. In fact, like doula, you could argue that that's going to reduce costs. It's not it's an additional benefit, but it's probably going to reduce a hospitalization. Now you can agree or disagree whether that's good or bad, but it's definitely going to avoid a hospitalization because they're at home. But so you have things like that where, yeah, it's additional, but it's probably no additional cost. And then at the bottom there, again, we've already talked about this. There's a clickable source there on where we derive the number for the enhanced behavioral health there. So, all right, so we're going to go through some of these in terms of how we quantified them. I'm not going to bore you with all manner of actuarial calculations in terms of what we did, but you can see that for the 5 that are over there, I think we hinted at this before. These are relatively small costs. The total there being, everything is relative, right? It's 700 million, but relative to the billions, these are pretty small. And then you add the behavioral health on top. Just at a high level, what Ken and his team did is basically we use nationwide data that we have in our database. We applied, for example, on the fertility services, we applied the same limits. So on that second benefit point there, or that second bullet point where it says benefits include current limits and maximums set by PEB, which they have a limit of for IVF, I think it's 25,000. Is that right, Ken?
Yeah.
Yeah.
And
Oh, it's right there. I'm sorry, it's right there. Third bullet point. My bad.
yeah, and that limit is important.
Yeah.
If you totally remove, especially in something like fertility, if you totally remove that fertility limit, your fertility costs are going to more than double. Is what we found.
Yeah. So again, these are not, huge parts of the PEB plus benefit. But what is the dental vision and really primarily the dental. So again, we assumed the same limits that standard dental would have. So if there's a lifetime limit or if there's a limit on the number of cleanings or what have you, a lifetime limit on, say, orthodontia or something, that we assumed that those would be in place.
Yeah, and just minor stuff here, but we indexed that limit, that $25,000 limit for fertility on inflation. We don't do that for dental. Dental limits have not changed. Generally don't change. So the dental limit is not indexed.
And then by way of compare, so 4, basically 4 million in the low and the high. That's pretty material cost increase. And if you recall way back, the Optimus number was a fair amount lower. I want to say it was closer to 800 million.
Yeah.
Okay, so this is our induced utilization, and so again, this is just to recap. We talked about this already a little bit. This is because cost sharing is being eliminated. Utilization would go up. Again, whether that utilization increase is good or bad is probably a mixed bag. There's probably some logical limits in terms of how much utilization could go up based on medical management, fraud, wasted abuse, and things like that. There's things that kind of cross-cut here. If I had to characterize anything, I would say probably our high estimate is maybe a little heavy because of that. So that's why I think our range could come down a little bit. The Milliman team will have to powwow about that and kind of see where we land. But whatever it is, we'll update you in the December meeting. But again, those numbers are really driven by our modeling. We have models that are based on actual experience, actual people using actual plans that shows that when you have a platinum plan and you have a bronze plan, the same people with same risk profile, the platinum plan people will use more healthcare. So this induced utilization is real. It's a known effect. You can quibble about the magnitude of it, though, for sure. There's no doubt about that.
Yeah. Other thing I'll add here is that that uninsured induced utilization includes a component of pent-up demand.
Good point.
For the first year, that would eventually we're gonna spread this projection out or extend the projection out for 10 years. That pent-up demand might maybe not all be in that first year. It might be a slower curve, and
yeah. And I think that's especially true for the dental. His first year of dental is usually pretty substantive.
Yeah, and this induced utilization here, this is for medical and drug.
Medical only, yeah.
That those dental estimates that Fritz showed have their own component of induced utilization within them already.
Yeah. Betsy.
That pent-up demand, does your modeling sort of predict how long that tail is? And 50 years from now, everyone will always have had healthcare, and there will never be a time when we have people who've been putting off getting that crown or whatever. So obviously you're not looking 50 years out, but what's a reasonable estimate for when that might disappear?
No, I think that's correct. Certainly in the case of what we would call pent-up demand for the uninsured, for example, or for people that don't have dental, that's not going to be year over year over year. It would tail off, there's some judgment on that number, but you are directionally correct that it would not continue forever.
Mhm. Yeah, that would be that's something we'll be considering in part of our thought process for that 10-year projection. But I guess I haven't decided yet. We haven't decided yet.
Yeah. We're just at year one right now, so we'll start thinking about years two through 5 here soon enough.
Yeah.
All right, so now we get to Helen's question on.
Oh, we have one more question first.
Oh my goodness. Okay. Yeah, Chunwei.
This is not a question. This is a quick response to Betsy's question. Based on Taiwan's experience, prior to universal health care, only 52% of the population were insured. And in 1 year, that bumped up to 99% and quickly to 100%. And the induced demand in terms of those who previously uninsured now become insured quickly level off within less than 5 years. And that's out of 24 million population.
Yeah. All right. Very good. Let me scan here. No other questions. All right. So let's talk about the adverse selection. So the theory here, high level, is that since our great United States has porous borders, dotted lines around our states rather than hard lines that you might have in, say, England or other places that have national health care, relative to that, moving to a state to obtain a benefit such as universal health care will be relatively easy. A lot of this depends on administration and eligibility criteria, which are not determined yet in terms of well, at least not to my knowledge. Maybe you could correct me if I'm wrong, but for example, there might be a big difference in our estimate if you have to be a resident for a year versus 6 months versus 3 months versus 2 years versus whatever. So that type of a waiting period would have a substantial impact on some of these numbers. That said, we did a couple things to model this. This is probably the most. This is probably the number that could move the most in terms of how you think about it, how we model it. It's very assumption driven. My guess is that the real answer is not 0, but it's probably it almost with certainty it's not going to be the number we give you. That's just kind of the nature of predicting human behavior. However, thinking through it logically, you would, if you had motivation to move to Oregon to obtain universal health care, you would have to have number one, a condition that is, or health needs that are material, that make it worth you leaving your doctor, your family, what have you, to move to Oregon to have this done. Number two, those conditions would have to be reasonably predictable. In other words, you wouldn't move there in anticipation of, say, getting hit by a car or something like that, or having an accident of some kind. These would need to be costs that are pretty consistent year over year. And then number three, we assume that you would have a higher likelihood of moving to Oregon the closer you are. So we did an inverse sort of function, measured the distance between capitals, and we just did something to indicate distance. So someone with diabetes in Maryland is going to be less likely to move to Oregon than someone who is in Northern California, who can, could conceivably just go get a residence in Oregon and keep their house in Northern California. So these are the conditions that we picked for this preliminary modeling. I'm not going to read them. You can see them there. Probably the most, the ones that are maybe the most costly and or selective would be mental health, and in terms of the highest volume as well, is diabetes and the mental health substance abuse. So those either have a large number of people and or they have a large cost or they have the ability to be selected, where mental health and substance abuse is the one that is probably the most prone to it's mental health, substance abuse in terms of diagnosis. My understanding is that is very provider driven in terms of putting a diagnosis to a lot of things. So once they're diagnosed with that, then that's when their healthcare costs could go up. And if they anticipate that, then they could easily move. Okay, we got a couple people. I'm hoping they comment on what I just said there. So let's start with Gabriel.
Thanks, Fritz. This whole presentation is a real crash course for me in actuarial science. And I appreciate all the work that your team has put into this. On the particular question of trying to estimate this adverse selection and this in-migration, is how fuzzy must these estimates be? It's difficult for me to imagine how one is there data out there? Is there how do you estimate things like this?
Well, see, Gabriel, we were hoping that you wouldn't ask that particular question. So you're learning fast. Your crash course is learning fast. No, I mean, it's fuzzy. It's fuzzy. You're, like I said, I know it's not zero. Okay, that much we know for certain. You are attempting to predict human behavior, for which we don't have any data to show. I mean,
yeah.
So there is one proxy, and someone on another one of the UHP calls brought this up, and we have not actually looked into this yet. There is an analysis out there on the Medicaid expansion when states were side by side. One state expanded and one didn't, and sort of what happened on that. So I do think that could be informative for us, because that's clearly it's a different population, but it's, like I said, it's better than nothing. So we do need to do that, and we will follow up on that. That's a good reminder that someone said that. So, but in terms of that's just one subset of the population. That's one particular, this is a whole state where almost anybody from anywhere in the United States could move. That's kind of unprecedented.
There's no precedent. Yeah, it's hard for me to imagine where one starts.
Yeah. Chunwei was next, and then Antonio was third. So go ahead.
Yeah, regarding adverse selection, I just want to comment that, again, we don't have any data and experience, but there's one important factor besides health risk. That is, this universal health plan will be financed by tax. And we don't have the final rate yet, but I can estimate people who are in the upper middle and upper income, they will have to contribute way more than what they currently contribute to private health insurance.
Mm-hmm.
And so there's a potential, and again, we don't know what will happen. There's a potential, another kind of adverse selection, that is higher income people may want to move out of Oregon, and particularly higher income with healthy health status. And so I just want to comment that, again, the income tax will be another important factor of adverse selection.
Yeah, totally. And Chunwei, you're in luck too, because 2 slides down here, we'll talk about precisely that. So, Antonio?
Yeah, that's a great call out, Dr. Chi. I mean, one thing to think about this is to control for this. And in the governance board's consideration is to put some limitations and to draw some policies in regard to the limited utilization of somebody coming out of state. And I think that could be shaped in a couple of different ways. That could be, the first year of moving to the state, there could be some restrictions on the total utilization. It could be some restrictions on some of the more expensive care, like such as cell or gene therapy, or, somebody with, cancer care, right? It could be restriction on saying that somebody would have to have coverage coming into the state. So I know this isn't an answer, and it doesn't restrict these, but if this is a huge price point and thinking about, we might think about how we might moderate this figure for this. But I think of it similar in nature as somebody deciding to go to a school in another state.
Yeah.
There's out-of-state tuition. And so there are some policies that we might be considerate of how that might structure it, again, to moderate this.
Yeah, that's well said. There obviously are policy levers that you have. And we don't have any of those policy levers built into this. And quite honestly, I don't know what our estimate would do. If you gave me a policy limit, we would really have to think about, okay, well, what's the actual effect of that going to be? I like the idea, though, just very quickly, the idea of someone comes to the state, and maybe newcomers, you provide primary care, as a sort of a first 6 months, 3 months, pick a number, where they at least get primary care. That by itself could be something where that could be enormously beneficial, because primary care, as you know, is notoriously cheap compared to some of the other forms of care that you can get. But anyway, that's just a thought. It's my opinion.
Yeah, Fritz, one thing to add, just something to touch upon in the comments here. Jamie has a comment that I think I want to talk about real quick. The no sense in coming here for a chronic disease if you can't get an appointment. And that's fair. And also with something like cell and gene therapy, right now we've assumed these increased costs in cell and gene therapy. We've assumed some people are going to come move to Oregon. On top of that, because of cell and gene therapy, but the reality is that cell and gene therapies are very difficult, and there's only so many facilities right now that can handle that, and those facilities themselves can only handle so many cell and gene therapy patients. So again, it's just getting to this. Yeah, there are some limitations on what capacity really there is for some of these, many of these conditions.
Yeah, that's a great point, Ken. And I think just thinking ahead to the report, I think it's important that all of this gets considered, and that it gets discussed in the report, but that it's caveated that there's a great deal of uncertainty around all of this because of the fact that it's unprecedented. And like I always like to say, human behavior is notoriously hard to predict. So it all looks great on paper, but that's also why we use a range as well, is to kind of try to consider the uncertainty around so much of this.
Yeah, and if we focus on the knowns rather than unknowns, what we do know, at least have a better idea of, is what someone with COPD or diabetes, what that cost is.
Yeah,
which is numbers a better idea of.
Yeah, that's a great segue. So we do, yeah, not all. So going back to Gabriel's question, not all of this is fuzzy. We do have some costs and things here. So we do. So this is sort of how we did the adverse selection by condition, and you can see most of this is going to follow sort of overall prevalence of disease. So the bulk of it you can see is, and there's a lot of people with multiple conditions too, by the way. You can have people with multiple conditions, but just doing a single view, you can kind of see the distribution of the conditions there. Diabetes by far being the largest, and then again, and this is where you can really quibble with us. You can convince us of almost anything on this state distribution. And may probably on the overall volume of movement too, but you can see that's what we did for adverse selection by state. Part of that is, obviously volume driven as well. California is the biggest state in the nation. So it makes sense that you would get probably more from that state just because of the volume. But then there's a proximity variable in there as well that we factored in. And then, of course, the blue, I'm sorry, the orange is just all other 46 states, right? So it's large just by volume. So that's a little bit about how we did that. And then you can see here, hopefully you can see my mouse here. Let's just focus right here on this line. Can anybody see my mouse moving there? Don't look at all this stuff up here. That's going to overwhelm people. Let's just look here. On the low side, you can see that's about, potentially 50,000 people. Now, again, keep in mind that 40,000 people is 1% of the state's population. So just to put that into perspective. So this is a little over 1%. And then on the high side, a little bit more. Up here, Ken, am I mistaken? Did we not put in the cost per oh, we didn't. Shoot. Okay. I think cost per condition is probably something we should have put on there, but if I remember correctly, Ken, correct me if I'm wrong, all of these conditions all had an average annual cost of over $30,000. And I think some were approaching $40,000 to $50,000 on average. So people could be zero in 1 year, but they're 80,000 the next year. So all relatively expensive conditions and predictable. And then we discount it sort of by distance, and this is what we come up with.
And that number at the bottom there, that population leaving Oregon, that's an initial estimate of those higher income, higher health status individuals, families expected to leave, and that's based on 1% of households making above $200,000 a year leaving.
Yeah. So that, Chunwei, that goes to your question, and that's, again, this is something where this is more of a revenue, finance and revenue committee question and Eco Northwest, but this is an example of where you would want to try to coordinate estimates that if people are going to move away from the taxes and towards the benefits, you would want to make sure that we're coordinating those types of those assumptions. So to continue Gabriel's and borrow his term, again, this is not all fuzzy. It is based on actual costs, actual population distributions. What is fuzzy is how people are actually going to react. Okay, so don't want you to think that we're just plucking numbers out of the air on everything, but we are predicting human behavior. So, okay, so that takes us to our last slide here. We're going to talk very quickly about some of these things we've already covered. The draft results that we have today don't reflect any of these things that we've put in here. So we talked about single payer efficiencies, both on the provider side and on the plan side, prescription drug rebates, medical management. We talked about the provider reimbursement reductions and sort of drilling down on sort of at least the dynamic of what could happen to provider reimbursement under the UHP. We will, in our report, we'll have some sensitivity analysis that will give people a sense for, well, what does it cost if trend goes up 1 point? What does it cost if utilization goes up? And this, so that people could that they can understand, what these sensitivities are. Same with adverse selection. If you get 5,000 additional people or fewer people, what does that cost? So all of that is things we need to add, and that will be in the report so that it is appropriately, so that people have the appropriate context around how much things could potentially move.
And I think if there's a sensitivity analysis that we haven't listed, or a way of viewing it that we don't have listed there, we're open to that. So let us know.
Yeah. So I'm not going to read through this list, other than to point out that in coming up, so after this meeting, like I said, we already have kind of our list, a punch list of things that we want to either provide an estimate for, some additional analysis, revise an estimate, or take your feedback. So that significant body of that work we are hoping to have done by the December meeting. But you can see sort of our punch list there. And then the last thing I would point out, so we have December, the December meeting, which, like I said, we'll move from like an 80% estimate here in terms of like confidence up to like a 90%. So we'll keep inching towards these final numbers. And then we'll have the meeting in January. I'm guessing at that point we'll have our draft report is due to you all by February. So even though I think we'll have a February meeting, we'll want to have a significant portion of the assumptions and all of the feedback baked into our analysis and our draft report sometime in January. All right, and that truly is our last slide.
Thank you so much, Fritz and Ken. We really appreciate it. It's just an incredible amount of work, really thought-provoking and really, really helpful to our work. So thank you so much. We have a minute if anyone has any final questions that they want to ask before we go on break and let Fritz and Ken go. Anyone?
I'd just like to say thanks. This was fascinating.
You're welcome. You're welcome. We're happy to help.
I don't see any other hands. Are there any other?
Looks like Antonio's got his up.
Okay, sorry, Tony.
No, sorry, I just popped up. Yeah, big thank you, great deal of gratitude in these, and there are a lot of assumptions, and I think I'd be curious just to digest this, just getting this today. Can these come out in the next couple of days? I assume we can take a look at it, and what mechanism as far as follow-up questions would that be?
I'll take that one, Tony. So this will be posted to the website, the slides, and then probably the easiest thing would just be to send us emails, and then we can get them to Fritz and Ken, and they're great about responding.
Spectacular. Yeah, thanks.
Yeah.
I guess one other question I have is regard to the provider payment, right? And some assumptions with that. And there's a lot that goes into that. We've put in together some ideas, and I would like to hear more about that, because it is in the different sectors, and that leads to more of the administrative content. You mentioned on the provider side, the administration, right? And how that might be cost neutral, as far as any universal healthcare system. I do have some questions regarding that. And how that provider payment takes place as far as global budgets and what we're going to talk about in a hospital, right? Versus a global payment for like primary care or fee for service versus pay for performance, value-based care. There's a lot of different flavors into that. So, and it's not for today, but I'd be curious to see if data is run and what an actuary look is, if it changes remarkably with those widgets and turning those knobs and everything. We're making assumptions that we're going to pay providers on existing constructs. I'm not so certain. I mean, I think we have some proposals, but that helps us actually think through what would be the best way to do payment in those different sectors of healthcare, or it would be information for the governance board to kind of weigh those options. So more just thinking out loud and how we might look at that.
Yes, and I want to clarify one thing, Antonio, because I may not have been, chances are very good I was talking too fast. My dial right now on provider reimbursement is that their reimbursement, that it's going to go this, there's no offset. I think it's going to go the same direction. In other words, they're going to have a reduced admin burden, which if you kept the revenue the same, that's less work, and so that's favorable for them. Then they're going to have an improved revenue collection because they won't have member cost sharing, so that's also favorable. So, but those are just two things. We'd have to, there could be other things you'd want. Like I said, there's probably puts and takes, but those are the two things that I mentioned, and they're actually going to both the same direction. So I just wanted to clarify that in terms of what I said. But I agree with you that very high level, depending on, let's just call it the mode of reimbursement, it could be more or less. Well, providers may have feelings one way or the other and want their revenue to go up or down depending on the type of reimbursement. So as an example of that, I might think that as a provider, if I'm put on more of a risk through, say, a global, maybe an episode of care type reimbursements, even a global budget would probably fall into this. Because they're on the risk, they're going to have they're going to want a risk, they're going to demand a risk margin. Because they would be like, well, you can't, we don't want to be underpaid. So there might be some of those dynamics that are going on depending on what gets instituted in terms of mode of payment, and then all the value-based and quality-based incentives that are built around that as well. But my concern in bringing this up is that if you put too much of that administration back over on top of the provider under UHP, then there's going to be, there could potentially be pushback on that. So that's just a high level way of agreeing with you, that I think there's a lot of different things to consider when you're talking about mode of payment. So anyway.
Yeah, thank you very much.
Okay, thank you again, Fritz and Ken. We really appreciate your time today and all the work you've put into this, and we look forward to seeing you again in December.
Okay.
At this point, we can take a 10-minute break, come back at 2:55. Okay, welcome back, everyone. Isabel, does it look like we have most folks back?
I'm not sure.
Let's see. Looks like Betsy, Tony, Angela are still waiting on, and Eve. Okay. We will continue on with our agenda. I'm going to pass it to Director McDonald to talk about our quality straw proposal.
All right. Hello, everyone. So if you can go to the next slide, Isabel, just to recap our quality of care with a strategy and policy proposal that was created was really the sense of creating a framework and ways in which Universal Health Plan could create a quality policy and a quality strategy. It isn't a strategy in and of itself. It was created using evidence-based framework, promoting the goals of the quintuple aim. Some of the additions and things that were emphasized were really prioritizing simplicity, reliability, transparency, and efficacy. And it was adapted from the WHO handbook for national quality policy and strategy. So some of the specifics were adapted a little bit based on feedback that we got from the group last month. So just next slide. So I've attached the revised straw proposal, and so it was sent out with this meeting. And a couple of things. I think one thing that was brought up is that and I think this might have been a little bit of perhaps not providing the best definition of it, but instead of using the word a local definition of quality, it was changed to a statewide definition of quality to bring about that concept of unity and ease and simplicity. Again, emphasize simplicity, included a sort of specific call outs that although we do want uniformity and specificity. We also want to make sure that innovation is allowed in quality strategies and policies, and then also responded to the recommendation that it was called out when talking about financing. The utilization of upside only risk interventions with primary care was recommended to be added to the straw proposal. So those are the additions that were made. I hope people have had a chance to peruse it. And if that is so, I'll turn it over back to Chair Blanca, and she can or ask for questions, or if she'd like to ask for people to decide if they like to take a vote.
Yes, so the full straw proposal is included in the meeting materials. If you wanted a chance to read through it, if you haven't yet. Anyone have any questions that they would like to ask Mimi or the team? I apologize, I can never see hands on this.
Oh, Jamie has her hand up.
This is very, very tiny, but in item number 6, paragraph 1, sentence 3, there's a little typo.
Thank you. Can you say that one more time, Jamie?
Item number 6, paragraph 1, sentence 3.
Thank you. Got it.
And again, I just want to say out loud, I'm so impressed with this and really appreciate all the work that was collectively done to get this looking so impressive and comprehensive. Thank you.
Great. Anyone else have questions or comments? Okay, so we should take a vote. So I'm looking for a motion to vote on whether or not we should advance this straw proposal to the board for their November meeting.
Mike raised his hand. Mike.
Oh, sorry, Mike. Oh,
Mike, you should be able to speak now.
Mike, you're on mute if you're
Mute. I think it's a fantastic proposal. I do though want to, and I want to get into the weeds for just a second, that in terms of I've spoken to a couple of people that have mentored me in terms of quality improvement, and what they're saying is that I want to speak to the 6 domains in the proposal. That yes, that's kind of standard traditional stuff, but there's beginning to be a lot of new research saying there's some weakness in how the domains have been being interpreted, and it has to do with things like the degree to which these domains help measure to what degree do people get back to independent function, their social connectivity, their to what degree do things actually stabilize the individual, and it appears that most places are not capturing kind of client stories regarding those dimension things. So all I'm suggesting is I think that this proposal is definitely good as is, but I hope we have the opportunity to maybe at least to do some further tweaking.
Thanks, Mike. Do any committee members have thoughts or questions?
Chun Wei has his hand up as well.
Yes, I just have a very brief question. One important guiding principle about quality is the state health priority and goal, and as I assume that will not be our work, that will be from Oregon Health Authority.
What was it? What do you think is?
the first guiding principle is about setting the goal and priority of health. And my question is that our task, or is that will be the task of Oregon Health Authority?
I mean, I think probably neither. I think, in the process of setting up the UHP, there will be a number of state level committees that will, address various aspects of the program. And one of those would be a quality committee, I would imagine. And so it wouldn't necessarily fall to OHA, but it would fall to a group that's not us, to work to define that and to build out the structure and, what kind of processes would be in place to assess quality and report on it, who would decide the metrics, that kind of thing. There would likely be a statewide committee. I'm not sure if we should specify that in this proposal. I don't know what others think. If we should say that we anticipate that if the UHP is instituted, that the public corporation that runs, or the governance board that runs the public corporation, would establish a statewide quality committee that would operationalize these principles. We could say something like that in there. But yeah, it doesn't specify right now who would do that, but it's
Yes,
not.
I think with that language in place will be helpful, because otherwise it's a bit odd to have this quality strategy, not knowing where that goal, the most important part is the goal and priority, and not knowing where that come from.
Yeah, I agree. What do others think about adding language like that,
Something that you just described.
Right. So the governance board, that if the UHP is operationalized, the governance board that is responsible for operating the public corporation would establish a statewide committee to implement, to develop and implement a strategy and metrics, something like that.
Actually, not the strategy or metric. It's more of the goal and priority, and
The
that
goal.
will guide
Okay,
the board in developing metrics, measurement, and strategy, detailed strategy, etc.
Okay. Right. That will, explicitly define the goals and quality measures.
Not quality measure, health priorities. It's in the upper level,
health
more
priorities.
fundamental level, and that the goal and health priority will then guide the quality indicator, measurement, strategy, etc.
Okay. Are we able to do a on-the-spot edit?
Well, if I may, I think, it is the very first of the detailed description. It says identify state health goals and priorities. And that's correct. It is somewhat vague. It doesn't say who is going to identify them, but it is clear that it is statewide. So to Helen's point, the reason it wasn't specifically called out is because it's a little unclear at this time what entity would do that. One could add in, the identification of the state health goals and priorities. You could add in verbiage regarding a statewide group, but I mean, I think it might be already implied in the description of how it's to be identified.
Yeah, although Chunwei's point was good too, that, it might be assumed that it's OHA and it's not necessarily OHA because they're also a statewide group. Yeah, I would be in favor of just saying that, the public corporation that governs the UHP would identify a health goal. To make it clear that that's the body that we're referring to.
Well, would you prefer to have that added, or send this to the board as is? And certainly there will be the opportunity for the board and others to weigh in and for this to be amended. So if it's possible, we could send it to the board like this, or if you want to added verbiage. I see Betsy Boyd raised her hand.
Yeah, I think from my perspective, I really appreciate Dr. G's call out, because I too write in language where it's often, the who is often implied. And it's so critical, I think, to have this be better and more effective than our system that we currently have, that I feel the danger of not specifying the who. However, at this stage, I would be okay with pushing this forward as long as we don't lose that if in the iteration to come, we make sure that is incorporated.
Yeah, I agree with Betsy. I think the committee today, we can approve this draft as to who shall make that decision about setting goal and priority. We can bring that up to the full board to discuss.
Okay. Any other thoughts on it? Or anything else? If you have your hand up, speak up because I can't see.
I don't see any hands up.
Cool. Okay. Well, then I'm looking for a motion to advance this quality straw proposal as is to the board for their November meeting.
I move.
Second.
Any further discussion? Okay, we can do a roll call vote.
Great. Helen Belanca,
Yes.
Chun-Wei Chi,
Yes.
Peter Addy is absent, Gabe Endine.
Yes.
Thank you. Betsy Boyd Flynn,
Yes.
Mike Durbin,
Yes.
Rob Fassett is absent, Rosemary Hemmings. Rosemary, if you're able to unmute and give your vote, otherwise we'll loop back. Okay, we'll come back to Rosemary. Julianne had to exit the meeting. Max Kaiser.
Yes.
Thank you. Jim McGee is absent. Peter Merritt.
Yes.
Thank you. Angela McCallick.
Yes.
Thank you. Jamie Osborne.
Yes.
And going back to Rosemary, are you able to unmute? Doesn't sound like it, but that's a majority.
It's a majority. Okay, great.
I also vote yes. Apologies if I missed my name.
Oh, thank you. Sorry.
Okay, excellent. Thank you. Okay, so I'm passing it to Lee now for a discussion on long-term care.
Great. Thank you. All right, let's just dive right in here. So these first several slides are going to give an overview of kind of what's currently going on in Oregon, and just fair warning, I am going to zip through those pretty fast. It's really meant for you to be able to use as a reference slide, and then we're going to focus on kind of the last third of this presentation, which is really about how other systems, other countries, that is, handle long-term care, and you know, what it could look like in the context of a single payer. So for a little bit of just context here, the Joint Task Force, as part of its recommendations, did issue a particular recommendation on long-term services and supports, or LTSS. That recommendation you can see right here, which is essentially that this would operate alongside a single payer healthcare system. So the Oregon Department of Human Services would continue to administer Medicaid LTSS benefits for those individuals who are eligible, and that coverage would not be universal. So it would not apply to all those who might have coverage under a universal health plan. They also recommended essentially not touching some of those other programs such as PACE that also serve to provide LTSS, and not getting involved in the private market either, so allowing that to continue to be available as people chose to buy into that. Next slide, please. So long-term support services, this is essentially a range of different services that are generally health adjacent. So really want to focus here on that second bullet, that LTSS differs from healthcare in that it's not necessarily there to treat a medical condition, but really to maintain a level of functioning and a level of quality of life. And this could be a short-term thing or a long-term thing. LTSS can be provided in the home, in community settings, or in facilities, such as if someone were to be in a nursing home or other type of institution. And eligibility is generally based around what we call ADLs, or troubles with activities of daily living, such as the need for people to be there, maybe for balance reasons or for mental or cognitive impairments. Next slide, please. Now, something that I think is important to remember is that actually the majority of LTSS is provided by unpaid caregivers. So it's provided by family members, friends, neighbors, etc. However, when it comes to those that are involved officially within our LTSS system, we of course have things like nursing facilities, assisted living, hospice, and other kinds of rehab or daycare types of things. In that table on the bottom right, you can see specifically the entities that are in Oregon, nursing homes, assisted living, and then about 1,400 adult foster homes. Next slide. As far as using LTSS, this is something that is pretty common. A little over half of adults that reach the age of 65 are going to require LTSS at some point in their life. And a little over 1 in 5 of all adults will require it on what's considered a long-term basis, which is more than 5 years of needing these supports. You can see there's a pretty significant caseload. The reason it's by month is because LTSS for the remaining 78% of folks is something that can be more temporary, maybe while they are recovering from a particular condition or while they are between various caregivers. So this is an area that does have a lot of turnover, but a lot of people touch this system. Next slide, please. As far as financing, or really we're talking about, who pays it and how it's paid, high income countries tend to provide LTSS through either social insurance, some kind of universal coverage, or means tested system. So that would be something akin to Medicaid that are applied to their citizens when they reach a certain threshold. In the US, our spending is actually below that of other high-income countries, and that's because we do depend so much on caregivers to be providing these services. They are not sponsored by the state. So a little bit of a mixed bag. We have lower spending, but also we are placing a higher burden on caregivers. Over half of our officially financed LTSS is provided by Medicaid, another 15% by Medicare. But there's a pretty significant chunk that is out of pocket, and then a smaller slice that we see is privately covered. But as the majority is Medicaid, we will spend a little while talking about what Medicaid does for these services. Next slide, please. Just noting that those costs can be very significant. We're talking hundreds of thousands of dollars. And a lot of this is, again, paid out of pocket for most Americans. Next slide. So again, Medicaid is the primary funder of paid LTSS services, and it comprises a significant portion of the federal funding that the Medicaid program receives. It's nearly a third, 31% for the year in which we have the most current data did go to LTSS. Now, notably, as you look at the blue circle or the one that's sort of in the middle of the slide, in case those colors are tricky for you. Oregon is actually #1 with respect to providing home and community-based LTSS versus institutional. So that's really fantastic and speaks to a lot of the great work that the Oregon Medicaid program has done to really keep folks in the community with this particular funding. Next slide. LTSS is a rapidly growing area of costs. For these years where we do have data, it pretty significantly outpaced inflation as well as healthcare costs, which is not too surprising when you consider that a lot of LTSS services are used by those 65 and older, and that is one of the faster growing segments of our population. Next slide. So outside of Medicaid, there is some coverage on the private side and there is some coverage on Medicare, but both tend to be pretty limited. On the private side, there are typically caps as to the amount of LTSS service that is covered. So that kind of indefinite ongoing is difficult to find. Additionally, a lot of people tend to lapse in terms of their private coverage. You usually have to pay in premiums for many, many years, and it's typical that you might stop paying those premiums before you ever need these services, or just never use them at all. That's extremely common on the private side. So that is part of the reason why we see just such a small percentage of the financing coming from private insurance. On the Medicare side, it is limited to specific circumstances. Specifically, Medicare really wants to have that medical connection. And as we discussed with kind of the definition of LTSS, it's not necessarily about treating a disease, but about maintaining that quality of life and assisting with those activities of daily living. But Medicare is only going to cover things when they are considered medically necessary. So that does pretty significantly limit the extent to which Medicare funding is directly available for these services. Next slide. Now back to Oregon. Oregon has done a lot of really great work with LTSS and with making sure that the Medicaid program is able to cover people effectively via 2 waivers. And this is the first of those, a 1915 K waiver. This is also commonly referred to as the K plan. But this is part of the demonstration that Oregon has done to really, really, really leverage home and community-based services and keep people out of institutions. And this has been in place for not too long, but a few years now, and has been extremely successful, as we can tell from Oregon being #1 with respect to the amount of their budget that goes towards home and community-based services versus institutional care. Next slide. On the 1115 side, Oregon has undertaken another demonstration, and this one is designed to be able to provide some LTSS coverage for those who aren't necessarily Medicaid eligible. So trying to avoid people essentially having to spend down all of their assets before they can access any Medicaid funding for this particular service. So that's one way of trying to keep people living in the same way that they have been living, staying in the community, etc., by making this available to folks not just at 138% FPL and below, but 400% FPL and below that have limited additional resources can be eligible under this 115 waiver. Next slide. So all told, when we look at Oregon's LTSS policy, we see there's very strong prioritization of using the least restrictive setting, which is fantastic. And then this somewhat controversial aspect of having some asset limitations for providing the full LTSS coverage of kind of an unlimited benefit. So while the Oregon Health Plan looks strictly at income and does not also look at assets, those that are receiving Medicaid, kind of the full Medicaid coverage for LTSS, not only need to show that income, but also limited asset. And this is a bit of a way of limiting how much of that full amount is being paid out. Next slide. All right, so now we're going to talk a little bit about some of the different options for LTSS. Essentially, how can this be handled in the context of kind of a social system, of a healthcare system, et cetera. So we see places that offer social insurance, and this is something that would be akin to Social Security coverage, where you pay into the system and then you're eligible to pull out of the system. So often funded through employee taxes or income taxes, something of that sort. Next, we have universal coverage, which doesn't necessarily require you as an individual to pay in, but does cover every single person that's within that system, typically funded through some sort of tax. But again, the difference being it's not necessarily that you, person A, have to pay into the system in order to be able to take back from the system, but that everybody is covered. We also have residual or means tested systems. This would be akin to Medicaid, where you become eligible when you hit a certain threshold. And so to qualify, you have to pass some sort of means test demonstrating that you are not able to otherwise secure these things. And then finally, there's all kinds of ways that you can combine these three systems to create different hybrids. Maybe something where it's universal coverage at a certain point, but there's also an expanded benefit akin to a social insurance if you have specifically paid in. There's just sky's the limit for how you want to mix and match these. Next slide. Now, worth discussing is Washington State, which is the only U.S. state that has passed its own long-term support services social insurance program. So this is something that Washington State now has in place that exists outside of Medicaid eligibility, because Medicaid is required to cover these services for those low-income folks that qualify. But Washington has the system that applies to essentially everybody who pays in. So we're really looking at that social insurance aspect where you pay in and that is your eligibility bit. These are mandatory contributions if you are employed, so your employer will automatically take it out. It is a 0.58% payroll tax. It does include a lifetime benefit that will be adjusted over time for inflation. And there is a 10-year vesting period, as well as needing the eligibility of difficulty with 3 or more ADLs, which are those activities of daily living that I mentioned. Now, as far as why they chose these different things, mandatory because they wanted to avoid adverse selection. So if you are working, you are put into this system. They did determine politically that 1% or more was just not going to be viable, was not going to pass. The lifetime benefit was really for that cost predictability, noting that that was the average cost for the first year of LTS. So providing a little bit of a cushion for those who need long-term services, some time for them to figure out how they're going to address long-term financing. And so a bit of support, but recognizing that full coverage might not be feasible within their other constraints. And then a 10-year vesting period, as well as the eligibility of difficulty with 3 or more ADLs. These were all program saving considerations, wanting to make sure that people did pay in, and also noting that private insurance generally kicks in after there's difficulty with 2 or more ADLs. So selecting to have 3 was yet another way of really making sure that the system is paying out for those folks that truly need these services, and a way for them to manage that cost over the long term and sustainably run a program. Next slide. Now, this is some good information that the Joint Task Force actually developed and put together. And I really like these, just examining how LTSS systems work in the context of single payer, and what others who have come before us who have looked at implementing single payer, what they have done and what they have thought about the possibility. I particularly like the quote in the middle there, which is why I've highlighted it, from Vermont as they were developing their system, just noting that the most successful models of long-term care are generally separate from healthcare benefits. Those other two generally noting that from a political perspective, including long-term support services with the universal health plan is very challenging because of the significant cost that we see in providing LTSS. Next slide, please. So looking at some other systems that already have single payer healthcare and how they manage LTSS, we see a whole variety of things. In England, it's a means tested type of system. Japan has something that is very comprehensive, mandatory for everybody over the age of 40. And in Germany, we see this as kind of a separate system. They really have these sort of 5 pillars, they call them, of social insurance, of which healthcare is one and long-term care is one. Next slide. I actually prefer this one just because I do think it's a little simpler to understand as we're looking at these single-payer healthcare systems and how they all function. You can see there are all kinds of decision points that these countries have made regarding whether income is a relevant eligibility criteria, whether there's a limited dollar amount benefit. You see in most cases where the answer is no, there are copays in order to help control costs. Some do a really interesting idea of providing a cash benefit to caregivers. And then a couple notable things. I'll say that Japan is probably the most generous. However, they have been struggling with the financial sustainability of their program. Germany has more limited benefits, but they do support caregivers and families with really robust leave policies. So really kind of using wraparound social policies to support strong long-term care without necessarily paying for official long-term care services. Yeah, and then finally, the Netherlands, just noting that one is also extremely generous. The Netherlands does actually have the highest proportion of spending on long-term support services, though, at almost 4.5% of their GDP.
Wow.
Next slide, please. So a few of my summary thoughts from this research. Most countries with long-term care systems, it is funded and managed separately from healthcare benefits for a whole variety of reasons. There are a range of policy options that are used to contain these costs, including limiting eligibility for benefits based on financial means, providing perhaps a limited benefit amount, or supporting caregivers and unpaid LTSS through other social policies. Also, just do want to note again, Oregon has really done substantial, really incredible work to support LTSS and keeping individuals in the community, something that I think we all agree is very important and would want to sustain. So in light of this, I do offer just this staff recommendation that in alignment with the Joint Task Force, individuals who qualify for long-term care should continue to receive benefits and services through Medicaid and the Oregon Department of Human Services. They have a strong system in place, and we've seen from other countries that there is a great deal of benefit to keeping long-term care as its own kind of stream of financing and rulemaking relative to health benefits. And with that, next slide, please. I will turn it over to the chair. These are a few questions you can choose to discuss if you like.
Thanks, Lee. That was great. So right now, in the estimates that we saw today from Milliman, the cost of long-term services and supports for the Medicaid population are included in those numbers. They're included for like our current estimates and our projection to 2030. For the UHP, the assumption that they made for long-term services and supports is that those would continue to be offered just for the Medicaid population. I think the folks on this committee will recall what we decided was there would be sort of a UHP plus. So like there's like a 2-tiered system for the universal health plan. So folks who would normally qualify for OHP would have slightly different benefits than everyone else. They would have you know, the regular UHP, but they also get non-emergency medical transportation and ESPDT services, and then this long-term services and support benefit as well. So right now it's in there for just that population. And I guess what we don't have to decide this today by any stretch, but just what I'd like folks to think about as we continue to mull over the expenditures work by Milliman is that I think I'm fairly certain that at some point we will have this, you know, projected expenditures, and we're going to have the revenue that is feasible to raise through the revenue strategy, and there's going to be a mismatch. And just looking at some preliminary numbers, our plan right now would be spending more than we would be able to bring in through a revenue strategy. And so if we needed to adjust the universal health plan, the question for this committee is going to be, how would we do that? What kinds of things would we adjust about the universal health plan to make it more feasible? One idea of many, I want to be clear, is that we could pull long-term services and supports out of the UHP altogether and set up some sort of social insurance program similar to other countries where it is run sort of separately from the universal health plan. The universal health plan only pays for direct medical care. And in this social plan, it would have its own revenue source. I don't know what it would be. We'd have to think about that. But it would be like a payroll tax like Washington does, or some other sort of revenue strategy. But it would be run separately. And those folks who normally would qualify to have all those long-term services and supports covered because they're eligible for Medicaid would continue to pay nothing for that. They would just be enrolled as they normally would. That would continue. But then everybody else, the rest of us in the population, would have some sort of cost sharing, either a premium or a copay to enhance that revenue strategy. But it would be like a public option for long-term services and supports. But it would just be taken out. Now, if we took it out of the UHP, Fritz showed the numbers and I meant to write it down and I didn't, but they actually can pull out of their numbers how much of the UHP we could attribute to long-term services and supports, and we could reduce our total expenditures by that amount. So that's one option. Of course, there are many. For instance, he mentioned dental is a really big cost, like upwards of $4 billion. And so it would be pretty easy to pull dental out of the universal health plan and make it its own insurance, again, free for those who would qualify right now for OHP. We wouldn't be removing any benefits, but we could just have that available as like a private insurance. If you want dental insurance, that's available sort of as a supplemental insurance for those who need it. So we're going to have to make some decisions at some point in this group about, you know, if there's a mismatch between expenditures and revenue, what should we do? And my main purpose of having Lee talk about this was for us to think about, is this one of the things that we would like to pull out, or is there some advantage to sort of keeping it in the UHP for Medicaid eligible recipients? We're not even discussing the question about making long-term services and supports available for everyone. That's just not financially viable. I think it's either like it's in there for OHP members or it's removed and provided in a different way. Any thoughts on that? I'll just stop there.
So it seems like whether we keep it in the universal health plan or pull it out, it's still Medicaid dollars that are paying for the Medicaid long-term services and supports, and would still have to be covered by tax dollars at the same amount, right? I mean, does it present savings if we pull it out?
In the sense that, I mean, there are still some state dollars that pay for it, but it would, in terms of the universal health plan, though, that expenditure would be removed from a UHP expenditure. It is really complicated, you guys, and I'm not going to be able to say accurately what happens, but there's something about the way the federal money that supports long-term services and supports goes through DHSS, I think. I don't know, folks on this, in this committee might know more.
DHS.
Yeah, right. And so it's not, it's a little bit convoluted already. And so it's money that is already sort of its own thing and could be taken out of UHP as an expenditure and just administered differently through DHS, and not administered as part of healthcare benefits. It would be just its own separate program. I really love Germany in terms of how they've set up their healthcare system, but just like there's, the UHP for your medical care, there's the long-term services benefit this way, they just separate it out into its own silo. So yes, there are some dollars that would still go there that are state dollars, but we wouldn't have to account for it in terms of a UHP expenditure as we come up with new revenue to support the UHP.
Got it. So I think my general thought is that what we go live with will be UHP 1.0. And then it will develop over time and things will be added over time. I would support leaving long-term services and supports exactly how they are in our state today, even given all the gaps and all the things, but make that like a 2.0 goal to address that issue once things have stabilized with the remainder of the health plan would be my thinking.
And if we needed to remove something, consider removing something else to make the revenue equation work.
Oh, no, I was saying leave it as it is today. So leave long-term services and supports with ODHS. Let people elect to get their own private long-term care insurance if they choose to do so. Out of pocket and caregiver supports are still the primary for most individuals. Would be my thought, that we don't muck with the long-term support system in 1.0.
Helen, I don't know if you can see, Chun Wei has his hand up.
I can't see, sorry. Yeah, thanks. Go ahead, Chun Wei.
Yes, I agree with Eva's comment. My main concern is by including the long-term care support and service within the same UHP, it will make our expenditure bigger, and that will have to be reflected in our taxation and finance. And that will present a very big risk of political feasibility of the entire UHP.
That's right. Thank you, Chun. That's, I guess you said it much
And so
better
that's
than I
my
did.
main concern. At the same time, we can propose that something of a social insurance, but not as the same administration, same implementation of UHP as a separate entity to develop plan, possibly a social insurance for long-term services and care in the near future. And so that separate that. Also, there's a big uncertainty about how we separate OHP, particularly given the current major budget cut. Unless the next administration are able to recover, there will be substantial budget cut to the federal funding available for OHP, and that also affected the long-term care under the OHP. And so we need to consider that. And I think it's probably safer to separate that from the overall UHP, make our finance and expenditure more predictable and more clear.
Yeah. Right. So there's two issues with leaving things as is. One, as Chun Wei just said, it raises our expenditures quite a bit by multiple billions of dollars. And the risk is that it might sink the whole plan. If we need a large personal income tax to cover all of the benefits, then that might sink the whole plan and doom the whole effort, right? And so we want to we want to make it as palatable, I guess, as we can in terms of new taxes. So it is a very big expense currently in the UHP. So taking it out would reduce our expenditures in a meaningful way. There's also a simplification thing too. It's simpler if everybody has the exact same plan and there's not a two-tiered system within the UHP. And one of the most critical ways to do that would be this long-term services and supports is one of the main reasons why there's a two-tiered system within the UHP benefit currently. So so it would simplify that quite a bit. But yeah, anyone else have thoughts?
Tony.
Yeah, I really appreciate the discussion. You know, I think when we had our earlier conversation around this topic, around the concern of taking on too much, I think we probably, from a value statement, all really support the inclusion of probably this as far as an equitable approach to coverage for people throughout their lives, and certainly connected to healthcare, long-term services and supports. I do worry just about the extent of what this means for that financial means of raising that. And you know, I think that you said it well as far as, you know, ideally this is a start, and that future inputs into this could be included down the road to accomplish this task. I just think I support, you know, the idea of the motion that these would be separated at this time.
Thanks, Tony.
I'm not seeing any other hands, but Angela put in the chat that she agreed that version 1 of the, or 1.0 of the UHP should be the most palatable to the public. And Betsy agreed.
And Gabe, looks like too. Okay, so in terms of us giving some direction to Milliman, do we have a pretty good consensus then that, like, just seeing what our expenditures would look like if we pulled it out and made it separate, and then kind of drafting up a proposal for what that would mean in terms of how it could be administered to ensure that nobody who currently is eligible for them and deserves them, would still continue to get them. We could draft up sort of a proposal for how long-term service and support might work, and then see what our expenditures, how they would change. Is that what we're in accordance?
Let me make that motion.
Okay, so Tony's making that motion. Is there a second?
Second.
Any further discussion? Specifically, if anybody disagrees with that, I'd really love to hear your point of view. There might be things we're not considering here. Anyone have their hand up?
Yep.
Jamie said, yeah, so from people from Washington might move here for medical care, and Oregonians move to Washington for long-term care. Yeah, they have to live there for 10 years, though. I don't know if you caught that. It's a 10-year buy-in for that. So that's a pretty big, but yeah, I know it'll be a little bit of picking and choosing. Okay. If there's no other discussion, we can do a roll call vote, and the vote is to remove long-term services and supports from the Universal Health Plan expenditures and draft a plan for how they would be managed separately. And we can do the roll call vote.
Great. Helen Blanca,
Yes.
Chun-Wei Chi,
Yes.
Peter Addy is absent, Gabe Endine,
Yes.
Betsy Boyd Flynn,
Yes.
Mike Durbin,
Yes.
Rob Pizzette is absent, Tony German.
Yes.
Thank you, Eve Gray.
Yeah.
Thank you, Rosemary Hemmings.
Yes.
Thank you, Julianne Horner had to exit, Max Kaiser.
Yes.
Thank you, Jim McGee is absent, Peter Merritt.
Yes.
Thank you, Angela Michalik,
Yes.
Jamie Osborne.
Yes.
Thank you. That's everyone.
Thanks, great. Isabel, has anyone signed up for public comment?
We have one sign up.
I'm wondering about the hospital straw proposal. Lee, do you think you can review that fairly quickly?
Yes, I can. I can even just jump straight to the summary slide.
Yeah, I want to put this in front of people, and this is already something that we already seem to be pretty much in agreement on. This would be our second straw proposal going to the board in November. If folks are concerned about it, if there's any discussion, we can table this to our November meeting. But if this is something that is pretty straightforward, that we can vote on today too, I would appreciate that. Yeah, go ahead, Lee.
Okay. Isabel, do you mind just, forward, please? So those were all back. So those were some of the graphs just demonstrating the discussion that you all had last time, but what it all boils down to are these key points that are in the proposal. So hospital global budgets as the primary methodology to reimburse acute care hospitals, and the global budget accounting for approximately 70% of hospital total payments, the remainder to be determined. Global budgets covering inpatient, outpatient, and physician services rendered at the hospital. Adjustments for critical access hospitals related to their reasonable costs. There was also support for add-ons essentially for other categories, but critical access hospitals, it was really clear we wanted special adjustments, so called that out. And then finally, that global budgets would be implemented in 3 to 5 years, with the proposal just putting out there as a thought, beginning at 30% and increasing 10% over 4 years. And that's that.
Does anyone have questions or concerns about this proposal or think we need to discuss it more?
Eve and then Chunwei.
Thanks. I am on the cost growth target work group, and we were discussing how the cost growth target came to be. And it turns out that that was legislative direction, I don't know when, but back a number of years ago, to create a system of hospital global budgets. And the work group got together to talk about it and rejected the idea and came up with the cost growth target instead. I suspect that hospitals had something to do with that and would really like to get hospital association input prior to a vote on this straw proposal.
Yeah, absolutely. So as a note, it's a straw proposal to the board, and we're just saying that this is where the committee thinks the board should go. As Mimi mentioned at the beginning of the meeting, we're about to launch on our a portion of our community outreach that gets input from interest groups. And certainly hospitals and other healthcare providers are a major interest group. And so the purpose of this straw proposal is to signal to the board what this committee thinks is the right thing to do. And then we would ask our CECC, Community Engagement and Communications Committee, to take it to healthcare providers and say, we're thinking global budgets that might look like this. What do you think of that? So the board is looking to this committee to get ideas to put in front of those groups. And so by voting on this and saying, yes, this is the straw proposal we think is the right one, we're just getting it to the next phase of vetting. And definitely that vetting is going to happen with healthcare institutions. This is not a final proposal. That's why we label them all straw proposals. They all will be reconciled at the end of our process based on feedback that we get from all kinds of interest groups, business groups, hospitals, and all kinds of other groups on our list. So it's just, is this the best thinking of this committee? And then we'll get input from others.
And Chunwei has his hand raised as well.
I have a clarifying question. At this stage of the straw proposal for the hospital global budget, we are just proposing the hospital's payment will be based on global budget, but we don't propose any more details such as this will be for the entire state or by region or how we divide the budget. Is that correct?
Right. It's not based on the region that they're in, although I imagine there will be regional differences in the global budgets. But yeah, it doesn't specify that.
So basically, this straw proposal is for committee to bring this up to the board, saying the board, we support the board to move toward hospital global budget, but without more detail. Is that correct?
Right. Except for the detail that Lee outlined here. Any other questions, thoughts? So again, I don't want to rush this. If we don't feel like we're ready to vote on it, it's okay to, as Eve said in the chat, either abstain from the vote, and if we don't have a majority, we don't have a majority, and we'll bring it back again. But if there is a motion to advance this straw proposal to the board, then we can just see where the committee stands. So do I have a motion? Ooh, so nobody's going to move to advance this to the board yet?
Wait, Mike
I-
raised
so-
his hand. Mike.
If I
no.
could make a comment, Mike, although you are a board member, since you're not a committee member, usually it's been the process of the committee that only committee members are generally encouraged to be part of the conversation. So I just wanted to say that. But it is at the discretion of the chair about who is speaking.
Yeah, so do any committee members want to make a motion about whether about advancing this to the board? If there's no motion, then we'll just table.
I move.
Oh, okay, so Chunwei's moving to for this. Is there a second?
I'll second.
Any further discussion? Okay, roll call vote.
Okay. Helen Blanca,
Yes.
Chunwei Chi,
Yes.
Peter Addy is absent, Gabe Bandine,
Yes.
Betsy Boyd Flynn,
Yes.
Mike Durbin,
Yes.
Rob Fizette is absent, Tony German,
Yes.
Eve Gray,
Abstain.
I believe I didn't quite
That
catch
she
it, but I
said
believe-
she said abstain.
yeah, okay, got it. Rosemary Hemmings,
Yes.
Julian Horner is not here, Max Kaiser,
Yes.
Jimmy Gee is absent, Peter Merritt,
Yes.
Angela McKaylick,
Yes.
and Jamie Osborne.
Yes.
Thank you, that's everyone.
Thanks, Isabel. Okay, great. We have 5 minutes remaining. Before we hear from public comment, first of all, I want to thank all the committee members for your participation today. This group is super helpful to our process. I wanted to just ask if anyone has any feedback or requests or things you feel like you need more information about as we go forward with the work with Milliman and quality hospitals, anything. If there are requests that you have, we'd like to hear them now and we can plan for that.
Let me just jump in.
Thanks,
Really
Tony.
appreciate Milliman's presentation today, and I know it may be kind of up to the minute, but if they could provide that information in advance of meetings, I may have missed it. But I didn't see it come. I just seen it today. So if there is ability for us to prepare and kind of look through things, I think that would be optimal. I know that is not always the case.
Yes, thanks, Tony, for saying that. That's been our request to them, and that's sometimes feasible and sometimes not. But I agree with you. We do have the same request for board meetings, is to get materials out in advance. So we'll make sure that that happens for next month. It should be much easier next month. Anything else? Requests for more information or topics you'd like us to discuss?
Rosemary had her hand up. I apologize.
Yeah, I just wanted to second that. That was a lot of information. It would have been helpful to have it in advance. Yeah.
Great, thanks. It's a little one of the things with Milliman is their slides are proprietary, and so when we did get some slides in advance, but they weren't the same ones that we looked at today. And yeah, but we'll continue to give them that feedback because yeah, I'm the same way. I know it's really helpful to see it in advance. Thanks though. Anything else? Any other requests? Okay, then we can go to public comment. Isabel, if you can introduce our commenter, and they will have just 2 minutes.
Yes, so as always, public comment is greatly appreciated. Public comment can be submitted at any time via the website, and written public comment is posted with the materials for this meeting. We ask that written public comment submissions be sent 72 hours in advance of the meeting, and for oral public comment that people sign up 24 hours in advance. Today we have 1 speaker. You will have about 2 minutes. I'll put the timer up on the screen, and Dawn, whenever you're ready, you may begin. Dawn, if you're would still like to give your comment today, you may begin at any time.
Is it Dawn Regier?
Yes, that's you.
Oh, I was wondering if you had gotten my message because I thought I was speaking last month, but I would just like to advocate for out-of-state healthcare for Oregonians or out of country, that they be covered when traveling. And that's what I would just like to advocate for. So they're covered everywhere. They don't have to get out of country or out of state insurance to travel.
Thanks, Dawn. Is that are you finished? Sorry.
Thank you.
Thank you. Yeah, the committee did take up that issue, and we do have a provision in there for Oregonians who travel. So, but we appreciate you bringing that up. Thank you. Okay, and with that, we are adjourned. Thank you all so much for your participation, and we will see you in December.
Thank you all.